$5.3 trillion. That is what the United States spent on healthcare in 2024, not the GDP of a small country. The annual healthcare bill of one nation, 5.3 trillion. That is 18% of everything this economy produces. Every car, every house, every software subscription, every meal out. And $1 in 5 of all of it goes to healthcare. And it's growing. Healthcare spending rose 7.2% in 2024, in a year when overall inflation ran at 2.7%. CMS projects that number will hit 8.59 trillion by 2033. Per capita, that would be $24,200 per American per year. That is more than one-fifth of GDP, an all-time high. You have probably felt this personally. Your premiums went up again. Your deductible is higher than it was 5 years ago. The average family premium in 2025 hit $26,993. That is a 26% increase since 2020 and a 53% increase since 2015. So the question every patient, every employer, every hospital CFO, and every policymaker should be asking is, where is all the money actually going? Because the answer is not simple. It is not one villain. It is not one broken part. It is 5 interlocking systems, each with its own logic, own reinforcing the others. And together, they have built a machine that costs more every year and delivers outcomes that, by international comparisons, should make us furious. Today, on Behind the Business of Healthcare, we are going to take that machine apart piece by piece. We're going to follow the money. And at the end, we're going to talk about what patients can actually do about it and what healthcare leaders need to change. Let's get into it. Before we get into the 5 drivers, I want to acknowledge something. Healthcare cost conversations are deliberately made complicated. The pricing is opaque by design. The contracts between hospitals and insurers are confidential. The formularies that determine which drugs get covered and at what price are not disclosed. The markups on procedures are not posted on a website. That complexity benefits the entities that profit from it. It does not benefit patients. And it makes it harder for healthcare leaders to identify which cost levers they actually control versus which ones have been decided by market structures above them. So, what we're going to do is name the 5 structural drivers clearly. Some of them are decisions made by the system, some are decisions made by society, some have solutions that already exist. None of them are inevitable. Here are the 5: administrative complexity, the consolidation of hospital markets, the chronic disease burden, pharmaceutical pricing, and the way we pay for care, or more precisely, what we pay for and what we don't. Let's take them one at a time. Driver number 1 is administrative complexity, and it is the most maddening item on this list because almost none of it delivers clinical value. The United States spends more on healthcare administration than any other nation on the earth. In 2021, U.S. healthcare administrative spending was $1,055 per capita. The second highest, Germany, at $306 per capita. We spend more than 3 times what the next most expensive country spends just on paperwork. Across the system, administrative complexity is estimated to account for between 15% and 30% of total healthcare spending. A 2020 healthcare affairs analysis estimated that wasteful administrative spending alone, the portion that generates no clinical value, runs between $285 billion and $570 billion per year. Why so much? Because the United States runs its healthcare system through hundreds of different payers, thousands of insurance plans, each with their own forms, their own coding requirements, their own prior authorization rules, their own appeals process, their own provider directories to maintain. Every provider in the system has to navigate all of them simultaneously. Administrative tasks cost the physician workforce an estimated $68,000 per physician per year in time and staff resources. For a 200 physician hospital system, that is $13.6 million annually, spent not on patient care, but on convincing insurance companies to pay for patient care. And patients are not insulated from this. A study found that U.S. employees spend nearly $21.6 billion in time and resources per year coordinating with health insurance administration. That is your time on hold, your hour fighting a denied claim, your week waiting for a prior authorization to go through before you can start treatment you have already been prescribed. 1 in 4 patients experiences difficulty accessing care because of administrative barriers, billing disputes, prior authorization delays, and coverage confusion. 25%. That is not a rounding error. That is a quarter of the patient population being delayed or blocked from care by paperwork. Prior authorization denials are appealable. Studies show that up to 75% of denied prior authorizations are overturned on appeal. But most patients never appeal because they don't know they can. The fix is well understood: standardization, electronic prior authorization, streamlined claim processing. Other countries have done it. The challenge in the United States is not technical, it is political. Every layer of administrative complexity is someone's revenue stream. Cost driver number two is hospital consolidation, and this one is the most underreported story in American healthcare. In 1970, 90% of the US hospitals were independent. Today, the number has collapsed to 32%. Nearly 70% of the US hospitals are now part of a larger health system. From 1998 to the year 2023, there were over 2,000 hospital mergers and acquisitions. And in 2024, 97% of the metropolitan statistical areas had hospital markets that qualify as highly concentrated under standard antitrust guidelines. Now, here is the economic consequence of that concentration. When a hospital or health system doesn't have a meaningful competition around it, it has pricing power and it uses it. It is not uncommon for hospital mergers to generate price increases of 20% or more. Some studies have documented increases of 40% to 60% in the years following consolidation in a local market. This is not an abstract policy problem. In 2024, a National Bureau of Economic Research paper traced a direct causal chain from hospital merger driven price increases to higher employer insurance premiums to reduction in workers' wages and employment. When the hospital down the street raises its prices because it bought its only local competitor, your employer passes that cost to you in higher insurance premiums and lower raises. And physician consolidation is accelerating alongside hospital consolidation. In 2012, less than 30% of physicians were employed by or affiliated with hospital systems. By 2024, that number was 47%. And studies consistently show that when physician practices get acquired by hospital systems, prices for the same services go up, sometimes dramatically, because they are now being billed at hospital facility rates instead of a physician office rate. If you live in a market with only one or two hospital systems, you are almost certainly paying more for care than patients in competitive markets. That is not a reflection of quality, it is a reflection of the absence of competition. Check if your hospital is part of a large system. For non emergency procedures, it is worth asking whether a procedure performed in a physician's office or ambulatory surgery center would be covered at a lower cost sharing rate than the same procedure in a hospital outpatient setting. Here is the piece most patients never factor in. If you have insurance, you already know you are probably going to hit your deductible and your out of pocket maximum no matter where the procedure happens. So the price difference between having it done at a hospital versus an ambulatory surgical center, which is almost always cheaper, does not feel like your problem in the moment. But that difference does not just disappear. Your insurer still pays it. And when enough of those higher dollar hospital claims get paid out across the risk pool, that cost gets built into the premiums for the following year. You will not fill it on the day of your procedure. You will fill it in the next year when your premium goes up because of decisions about where care got delivered that you never even realized you were making. Cost driver number three is the one that is least about the healthcare system and most about us as a society, though the system carries enormous responsibility for not solving it. The CDC estimates that 90% of all healthcare costs in the United States goes towards treating chronic disease and mental health conditions. 90% of a $5.3 trillion annual bill. That is approximately $4.7 trillion per year treating conditions that are, in large measure, either preventable or manageable with the right intervention. The numbers by condition are staggering. Cardiovascular disease costs the healthcare system $223 billion per year. Obesity costs the system $173 billion annually. And 40% of the US adults now have obesity. Alzheimer's and dementia care runs $360 billion per year and is projected to approach $1 trillion by 2050. Diabetes and prediabetes together cost over $327 billion annually. And a 2025 analysis by the Partnership to Fight Chronic Disease projects that if current trajectories hold, chronic disease will cost the United States $47 trillion between 2024 and 2039. That is $2.2 trillion in annual medical costs and $900 billion per year in lost productivity by 2039. I know that is a lot of numbers in a short amount of time. If you need to, pause this and rewind 30 seconds because those figures are the whole ballgame for what's driving your cost. Here is the paradox that sits at the center of this cost driver. The interventions that would most effectively reduce the chronic disease burden are largely not the things that healthcare systems get paid to do. We have a healthcare system that reimburses procedures and treatments. It does not reimburse behavior change, community level prevention, food access, or the social elements of health that drive chronic disease in the first place. A cardiologist gets paid for a stent. A primary care physician gets paid for a 15-minute visit. Nobody gets paid for the sustained long term relationship that keeps the patient from needing the stent. The Partnership to Fight Chronic Disease analysis found that better prevention, earlier intervention, and improved chronic disease management could prevent 150 million new chronic disease cases, save 13.5 million lives, and avoid $7 trillion in costs between now and 2039. That is not a theoretical number. That is the gap between the trajectory we are on and the trajectory we could be on with different policy and care model choices. Value based care contracts are the financial mechanism that begins to align incentives toward prevention. If you are a healthcare leader who has yet to make the internal investment in care management, population health infrastructure, and preventative services that VBC contracts reward, you are building a delivery model for a payment system that is being phased out. The transition is accelerating. Chronic disease is not simply a personal health failure. It is the product of food environments, economic stress, inadequate access to primary care, and a healthcare system that is not designed or paid to catch problems early. But within that system, primary care and regular prevention screenings remain the single highest leverage tool available to patients personally. The U.S. Preventative Service Task Force publishes evidence based screening recommendations for every major chronic disease at uspreventativeservicestaskforce.org. Most preventative screenings are covered at no cost sharing under the ACA. Using them is one of the highest return investments you can make in your own healthcare costs. Cost driver number 4 is pharmaceutical pricing. And this is the one that most directly reveals the gap between what the United States pays for healthcare and what every comparable nation pays. The United States does not negotiate drug prices at a national level the way every other wealthy democracy does. In France, Germany, the UK, Japan, Canada, governments negotiate with pharmaceutical manufacturers from a position of unified market power. In the United States, until very recently, Medicare was specifically prohibited by law from negotiating drug prices. That ban was a policy choice, not an economic predictability, and it cost Americans hundreds of billions of dollars over the decades it was in effect. The result of that policy environment is a pricing structure that is simply indefensible on the merits. Take insulin, perhaps the most documented example. A 2024 RAND Corporation study found that U.S. gross prices for insulin were nearly 10 times the average prices in 33 OECD comparison countries. 10 times. After accounting for rebates and discounts, net prices were still 2.3 times higher than a comparable nation's. The cost to manufacture insulin, meanwhile, has been estimated by researchers at Yale at between $2 and $4 per vial. By 2017, a vial of Eli Lilly's rapid acting insulin was priced at $275. The economics of that gap are not driven by production costs. They are driven by a pricing environment with minimal competition and no government negotiation. And insulin is not unique. Spiriva Respimat, a common inhaler for chronic pulmonary disease, costs over $120 per dose in the United States and approximately $1 in Canada. Common diabetes and hypertension medications run 3 times the Canadian price on average. And now add GLP-1 drugs, Ozempic, Wegovy, Mounjaro, into the equation. These medications, originally developed for diabetes, have become the most talked about pharmaceutical development in a generation because of their documented effectiveness for weight loss and their potential to reduce chronic disease burden downstream. But at roughly $1,000 per month without insurance coverage, they are also a significant new cost pressure on the system. A 2025 Christensen Group survey found that 56% of employers said GLP-1 spending was driving healthcare costs to a great or very great extent. In December 2025, GLP-1 prescriptions filled were nearly double what they were in December of 2024. The trajectory is steep. The GLP-1 situation captures the central tension in pharmaceutical cost policy. These drugs may reduce costly chronic disease complications at scale, which would be a net savings long term, but they create significant short term spending pressure that plans and employers are struggling to manage right now. For patients, drug pricing complexity directly harms you. The list price on your prescription is rarely the actual price the system pays. GoodRx and similar tools often surface prices below your insurance cost sharing. Biosimilars, FDA approved equivalents to brand name biologics, are frequently available at lower cost, but not always offered proactively. You have to ask. Before filling a prescription, check goodrx.com. It surfaces cash prices and discount cards that often beat your insurance copay. Ask your pharmacist about biosimilar or generic alternatives. For high cost specialty drugs, ask about manufacturer patient assistance programs. Most large pharmaceutical companies offer them. Cost driver 5 is the architecture beneath all the others, the fee for service payment model that still dominates American healthcare. Here is the fundamental logic of fee for service. Providers get paid for every service they perform. More visits, more tests, more procedures, more imaging, more interventions, more revenue. The system is not designed to pay for keeping patients healthy. It is designed to pay for treating patients when they are sick. The misalignment has measurable consequences. A 2019 JMA analysis estimated that between $760 billion and $935 billion in US healthcare spending per year, roughly 25% of total spending, is waste. The six categories of that waste: pricing failures, administrative complexity, overtreatment and low value care, failure of care delivery, failure of care coordination, and fraud and abuse. Overtreatment alone, that is care that is performed but does not improve patient outcomes, is estimated at $75 to $100 billion annually. That is not malicious, it is the logical output of a system where the financial incentive is to do more. A spine surgery that may or may not improve a patient's back pain generates revenue. Physical therapy and lifestyle modifications, which may produce better outcomes at a fraction of the cost, are reimbursed at rates that make them economically unattractive for the system to prioritize. The incentive is built into the architecture. The shift that is already underway, and that both patients and healthcare leaders need to understand, is the movement toward value based care. Under VBC models, providers are paid based on patient outcomes and cost efficiency, not on volume of services delivered. CMS has been the primary driver of this situation through programs like ACOs, accountable care organizations, and Medicare Advantage quality linked payments. The evidence on VBC is promising but uneven. ACOs have demonstrated meaningful reductions in spending and improvements in care quality in some settings, but the transition has been slow. Adoption is fragmented, and many providers are effectively operating under hybrid models, part fee for service, part value based, that create conflicting incentives. The payment environment is moving toward rewarding outcomes. Health systems that have invested in the care management infrastructure, the data analytics, and the population health capabilities that VBC requires will have structural advantages. Those that haven't are taking on increasing financial risk as the payer mix evolves. For patients, fee for service incentives are part of why you sometimes get more tests and procedures than you may need. You have the right to ask, is this test or procedure going to change what we do next? What happens if we don't do it? This is not second guessing your provider. This is participating in shared decision making, which is both a clinical best practice and your right. Ask your provider, what is the evidence that this test or treatment will improve my outcome? And are there lower cost alternatives with similar outcomes? The National Academy for State Health Policy maintains a resource on shared decision making tools at nashp.org. Let's step back for a moment because all five of these cost drivers, administrative complexity, hospital consolidation, chronic disease, pharmaceutical pricing, and fee for service architecture, have something in common. They are each the product of decisions: policy decisions, market structure decisions, investment decisions, political decisions. None of them are laws of physics. None of them exist in every comparable healthcare system. They are choices this country has made. Some deliberately, some by default, some under significant lobbying pressure for industries that benefit from the status quo. And that means they can be unmade. Not easily, not quickly, but each of these five drivers has a documented evidence based intervention that would meaningfully reduce it. Other countries have implemented these interventions. The evidence exists. The question is whether the political and market will exist to act on it. This is a question for policymakers, but it is also a question for healthcare leaders and for patients who vote and make purchasing decisions and have more agency inside the system than they're usually told. So let's close by talking specifically to each group. If you're a hospital administrator, a CFO, a CMO, a health system executive, or a policymaker, here are five priorities the evidence points to. Treat administrative cost reduction as a margin strategy. Pressure test your market position for regulatory risk. Accelerate your value based care infrastructure. Make chronic disease prevention a revenue strategy, not a CSR initiative. Lead the pharmaceutical cost conversation with your payers. The five cost drivers are not abstract macro forces. They are operational challenges with operational solutions. The health systems that build capability against each of them will have structural cost and quality advantages as the market evolves. And if you are a patient or a family member helping someone navigate this system, I want to be direct with you. You did not design the billing system or set pharmaceutical prices or approve the merger that made your local hospital the only option within 50 miles. You are living inside a system that was not built with your interests as the primary design principle. But inside that system, you have more agency than you are usually told. Here is how to use it. Appeal denials every time. Prior authorization denials and coverage denials are not final verdicts. Studies show that up to 75% of denied prior authorizations are overturned on appeal. Most patients never appeal because they don't know they can or because the process feels overwhelming. Your insurer is required by law to tell you the reason for every denial and to provide an appeal process. Use it. Ask your provider's office to help you. File for the clinical justification is not something you can document yourself. Compare prices before non emergency care. For any non emergency procedure, imaging study, or test, prices vary dramatically across facilities, sometimes by factors of 5 or 10, even within the same insurance network. Hospital price transparency rules now require hospitals to publish their negotiated rates for common services. Healthcare Blue Book, Fair Health, and your insurer's cost estimator tool all allow you to compare prices before you commit to a facility. Using them can save you hundreds or thousands of dollars in cost sharing. Check drug prices before you fill. The price your insurance charges for a prescription is not always the best available price. GoodRx and similar discount card services frequently surface prices below your copay. Ask your pharmacist about generic or biosimilar alternatives. For expensive specialty drugs, check the manufacturer's patient assistance program. Most major pharmaceutical companies offer income based programs that can dramatically reduce your out of pocket cost. Under the Inflation Reduction Act, Medicare Part D out of pocket costs are now capped at $2,000 per year starting in 2025. Invest in preventative care while you have it. Under the Affordable Care Act, most preventative services, screenings for cancer, diabetes, hypertension, and other chronic conditions, are covered at no cost sharing on qualifying plans. That means you pay nothing out of pocket for the screening that could catch a problem before it becomes a catastrophically expensive treatment. The U.S. Preventative Services Task Force at uspreventativeservicetaskforce.org publishes a complete evidence based list of what is recommended for your age and risk profile. The single most cost effective thing you can do for your own healthcare spending is show up for the screenings you are entitled to at no cost. Ask the questions that protect you from overtreatment. In a fee for service system, the financial incentive is to do more. That does not mean your provider is acting in bad faith. Most are not. But it does mean you are not being protected by the system's incentives. Ask, is this test going to change what you do next? What is the evidence that this treatment improves outcomes over watchful waiting? Are there lower cost alternatives with similar evidence? These are not adversarial questions. They are how you participate meaningfully in your own care. You are not a passive recipient of whatever the system decides. You can appeal, compare, ask, and advocate. None of it is fully fixes the structural problems we covered today, but all of it puts money back in your pocket and better care in your hands. The U.S. healthcare cost machine keeps running because it serves too many powerful interests to be easily stopped, and because the people it hurts most have historically had the least power to change it. But that is changing. Hospital price transparency requirements are publishing data that was previously confidential. Drug price negotiations in Medicare is now law. Antitrust enforcement on healthcare mergers is tightening. Value based care models are rewarding outcomes over volume. None of these changes are fast enough. None of them are fully sufficient, but each of them represents a structural lever being moved in the right direction. The healthcare leaders watching this have a choice about which side of that shift they want to be on. The patients watching this have a right to understand a system that affects everything about their lives, their health, their finances, and their family security. That is the behind the business of healthcare costs, and it belongs to everyone in it. If this episode helped you understand something about your own healthcare costs or your organization's cost strategy, share it. These conversations are most useful when they reach both sides of the equation at once. All sources are linked below, including the CMS spending data, the RAND insulin pricing study, the KFF consolidation analysis, the JAMA waste estimates, and the Partnership of Fighting Chronic Disease projections. They're worth reading. Subscribe for more on the business and the human reality of American healthcare. See you next time.